It's time for another enlightening edition of Clock Conversations. I'm David Airdrie from Thrombosis Canada, and alongside our expert co-hosts, Dr. Maha Othman and Dr. Jamil Abdurrahman, we're bringing you the latest breakthroughs in thrombosis diagnosis and management. Hear from leading researchers, discover cutting-edge techniques, and explore the resources Thrombosis Canada offers. Let's get started.
In this episode, we'll be discussing a paper from Thrombosis Research entitled Anticoagulation Stewardship, Improving Adherence to Clinical Guidelines and Reducing Overuse of Venous Thromboembolism Prophylaxis in Hospitalized Medical Patients. We're pleased to have the lead author join us from Vancouver, Dr. Tony Wan.
Dr. Wan completed his internal medicine residency and general internal medicine fellowship at UBC before he went to Ottawa to complete a clinical fellowship in adult thrombosis medicine. Dr. Wan is the co-director of the St. Paul's Hospital Thrombosis Clinic in Vancouver, and he is a member of the Royal College AFC subcommittee in adult thrombosis medicine. Thank you so much for joining us and participating in our podcast. So perhaps we can start with a quick question. What was the motivation for this quality improvement project?
Thank you very much for inviting me. I want to first say that my colleagues, Dr. Drury and also Dr. Stephanie Garland, are pharmacist specialists. Unfortunately, cannot make it today. This all started when Dr. Drury and I attended the 2022 ISTH Congress in London, when we heard a group from the UK talk about their VTE prevention program in their hospital. They have a systematic process of assessing risks, prescribing appropriate prophylaxis, and monitoring key metrics. And they show very impressive results of reducing inappropriate use of prophylaxis and also reducing the number of hospital-associated venous thromboembolism. So we thought that it would be very helpful to have something similar in our hospital. However, in my personal experience as a general internist, I think in our hospital, not so much prescribing prophylaxis, more over-prescribing prophylaxis is probably the issue. So when we did a brief chart review, we indeed confirmed our suspicion. We found that quite a few of our medicine admissions who were low risk of VTE according to improved score were actually given prophylaxis in hospital. And that's how we started our journey in our stewardship program.
Thank you.
Great. So could you give us a brief overview of what a quality improvement project is and how it differs from standard clinical research?
The purpose of a QI project is to improve the quality of patient care and often focusing on a very specific process in a specific setting. Whereas clinical research, the goal is to generate new knowledge and often more generalizable. So an example I can give is there are clinical research looking at using clinical prediction tools and D-dimers to safely exclude DVT without using imaging. Whereas in a QI study, they may focus on how to reduce the number of people going to the emergency department for suspected DVT by improving the process of local physician. And also the methods are quite different. In research, the method is systematic, vigorous, often time-consuming, versus the QI method is more iterative, a little more trial error, making series of small changes, and which can sometimes move very fast. I think in a nutshell for me is there is more opportunity to take risks in QI and try new things and move on if one thing doesn't work out.
And how did you construct this multidisciplinary program? I mean, we're curious to know, how did you use an audit and feedback strategy to optimize that VTE prophylaxis based on the institutional policies?
Yeah, great question. This was a steep learning curve for us. Our group, we don't have any experience in running a stewardship program. However, we're fortunate that in our hospital, we have colleagues who established the opioid stewardship program as well as the antimicrobial stewardship program. So we spoke with all of them and got their insight. And we also spoke with colleagues across Canada. For instance, we spoke with the team who runs the Anticoagulation Stewardship program at the Jewish Hospital in Montreal. The overall theme that we got from talking to all these experts is that having a team of people with expertise in the area is the key. They've all agreed that is this regular dialogue between this expert team and your local physicians that drive the changes. And the other aspect is to actively try to sort out opportunity to improve. So that's when the screening and auditing process comes in. This allows us to identify areas for improvement and focus on them.
Okay, great. So there was also a component of the program in which you were deprescribing VT thromboprophylaxis in patients with alternative level of care status with prolonged admissions. Can you tell us about that as well?
Yes. I think this was a natural QI process, as we never planned to tackle that issue. In the beginning, we focus on assessing the risks and whether VT prophylaxis is appropriate for patients admitted under general internal medicine. As we expand our program to include patients admitted under our geriatric service, our geriatrics colleague, the feedback they gave us was that most of their patients, according to risk assessment tools, are high risk because they are elderly and most of them are immobile, meaning that most of these patients are on prophylaxis as a default. However, they brought to our attention that many of their patients stay in hospital long past their acute illness is resolved due to the need for rehab or need to wait for long-term care. Their question for us is, do these patients need to be on prophylaxis the whole time? Because the current practice is they do keep them on prophylaxis, and on the day of discharge, they automatically stop them. For them, this sort of doesn't make sense because the clinical status doesn't change. It's just the fact that the patient relocate from a hospital to a long-term care bed. That's the reason why they stop. So because they brought this up, we did some work. Again, this is an issue that there's no clear risk assessment model, no clear guidelines. So we talked to a lot of people, and we found out that many institutions or hospitals have their own policies or best practice guidelines. They're all very varied. At the end, we decided to create something that worked for our site. Working with our geriatrics team, these were the 4 things that we thought are very practical and important assessment factors. The first thing we looked at is the acute illness that brought the patient in the hospital resolved. For example, if they're in here for pneumonia, is the pneumonia resolved? The second thing we looked at is whether the patient has a surgical indication for prolonged prophylaxis. For example, hip replacement surgery or knee replacement surgery. The third item we look for is that have they received consistently 14 days of thromboprophylaxis while in hospital? We came to agree on this because of the 3 landmark trials on thromboprophylaxis in medical inpatients quite a few years ago. And most of these studies did not look at prophylaxis beyond 14 days. And lastly, the 4th item, we look for 2 very strong risk factors for thrombosis, including prior history of VTE or active cancer. We thought these 4 items are very practical and very important, and it's doable for us to standardize them, and the team agree, and we move on with it.
Thank you for this. Well, in the paper, you also explain in details the interventions were tested and modified through multiple cycles, plan, do, study, act cycles. There must be some challenges when you do that in several times. Could you tell us if you had any challenges and how did you manage them?
Yes, we indeed ran into a lot of obstacles. As you alluded to, the PDSA cycle is the core QI method. In our very first cycle, our big barrier was how do we effectively communicate to medical trainees? Because medical trainees are the people who are doing the hospital admission to our medicine units. And very naturally, they are the frontline clinicians who will do the VT assessment. The issue is that, like most academic hospitals, our medical trainees rotate every month, meaning that every month we have a fresh group of learners. We'll need to communicate to them how to properly assess VTE risk and how to properly prescribe prophylaxis. So the barrier really is, how do we communicate this consistently when there is a new group coming in? And one of the leading residents suggests that we create posters and visuals with a nice summary where we can post in on-call rooms in the workstations for the residents. So I think that was one potential solution, which worked a bit, not completely. And the other aspect was we actually went to the orientation, because whenever a new group of trainees enter the service, they have orientation during what we call morning report. So our stewardship team will go there and do a brief orientation at the beginning of each month.
Right.
So I think that was probably more helpful than the poster.
For sure.
Okay, great. So can you tell us about some of the financial benefits you noted over the 6 months of the implementation period?
The drug costs and the financial benefits actually our primary outcome measure of this QI project. We included the drug expenditure of enoxaparin 40 milligram syringes, enoxaparin 30 milligram syringes, and also heparin 5000 units, because those are the most commonly used thromboprophylaxis medications. And in the 1 year, what we call baseline period prior to the implementation of a program, the data from our hospital pharmacy database show that the cost of these medication on our medicine units were about $11,000 per fiscal period. The program was designed for financial reasons, so the data is organized in fiscal periods. Each fiscal period is 4 weeks, so essentially 1 month. Once we implemented our program in 6 months, we were able to drive the drug expenditure, the cost, down to about $5,500 per physical period. It's approximately a 50% reduction.
Great. Thank you. So I guess our audience would be curious to know what proportions of patients were receiving the inappropriate VTE thromboprophylaxis in your study. I know you show some nice graphs in the paper. And what was the level of acceptance of the recommendation that the stewardship program or team has made, and how did this get accepted by the admitting service?
Mm-hmm. Yeah, indeed, this was important metrics we track, because it shows whether we're making any progress. So at the very beginning, the percentage of low-risk patients, according to improved score, who were inappropriately prescribed prophylaxis during admission was about 40%. Over the 6 months period, we're able to bring it down. However, the numbers fluctuate quite a bit. And I think that is a reflection of the point that I mentioned earlier. Each month, we have a new group of residents that comes in. At one point, we were able to bring it down to about 28%. But by the end of 6 months, it went up to about 35% again. So and we see that there is some improvement, but still a lot of room to go. Regardless of whether the patient were prescribed an appropriate prophylaxis, despite the low VTE risk, as long as we're able to persuade the admitting service to deprescribe, we should be able to make progress. That's when the acceptance rate comes into play. When we first started the program, 60% of the time, our recommendation will be accepted by the admitting service. As we are more well established, as we reach out and speak with more people, when they get more comfortable, by the end of the 6 months, our acceptance rates are up to about 75%. So we're still seeing an upward trend. So hopefully this will continue to improve as we are more well established within our hospital.
Right. Well, this is great. I think it's great work, of course.
And what were the rates of VTE and major bleeding with the intervention?
Yeah, the rate of VTE and major bleedings were our balancing measure. We want to make sure while we're making some changes to the prescribing pattern, we're not causing a negative impact to patient care. So we were able to do retrospective chart review and look at the rate of VTE in 90 days for our patients. In the 435 low-risk patients who did not receive prophylaxis or had prophylaxis deprescribed at our recommendation, 5 of them, 1.1%, were diagnosed with a DVT or pulmonary embolism within 90 days. That is still reassuringly low risk. What we also found that was 3 out of those 5 patients were diagnosed with VTE when they were readmitted for another medical issue. For example, after the first index admission, they were readmitted for, let's say, heart failure. Is during that second admission for a different acute medical illness, that's when they developed the VTE. In terms of bleeding rate, we took all the low-risk patients and people who were not on thromboprophylaxis. The bleeding rate was 0.5%. Because of the chart review nature, we're only able to capture any bleeding that will occur while in hospital. Obviously, that may not extend to the full 3 months, which is often the definition used in research study. We believe that is a low enough bleeding rate to be acceptable. And I think it's also important to note, because if the patient was deemed to have contraindication for thromboprophylaxis, i.e. active bleeding or very high risk of bleeding in hospital, those patients were not included in our stewardship workflow. So this low risk bleeding may reflect us selecting a relatively more well patient, if you would say.
Well, clearly the program has been useful and, well developed. I'm curious to ask you, if someone would like to start an anticoagulation thromboprophylaxis stewardship team at their hospital, what would you advise them?
That's a great question. Looking back, I think the most important thing we did was to talk to people who have experience in this area and learn from what they've done. And more importantly, learn from things that they found didn't work. It really saves us time, so we can focus on other things that may be more helpful. The other important aspect is to getting buy-in from the hospital administration. I know this often can be challenging. 2 things that I find helpful when discussing with them is focusing on the drug costs. And I'm sure we all aware hospital administrators are often very eager when a program or a project can help hospitals save money. And the other angle of persuasion I found helpful was focusing on planetary health. I know at least for us in our local hospital, we have made planetary health a priority in our health authority. So we were able to use that angle by saying heparin medication, usually produced by pig intestine, has a relatively high carbon emission footprint. So with that, I think we're able to get more of our administrators excited on our project.
Right, that makes sense. Thank you for sharing those advice.
So is there anything that we haven't discussed today that you would like to add?
I think it's a great discussion already. One thing I would like to add is we are looking into something more exciting to sustain our project. I know AI has been a very popular topic, not just in medicine. So we're dabbling into it. We're working with a data scientist in our health authority, hopefully to create an AI tool that can do the auditing, screening, and VTE risk assessment for us. We'll see how it goes. I know we have the first draft of the model. I've been doing some validation, at least in the improved score assessment tool. The AI program has been performing very well, except on the immobility item. Much like us in humans, I think AI so far has been quite inconsistent. So hopefully with more work, we can make this work. So that is an exciting next step for us.
Thank you.
Well, thank you. Thank you all for this great discussion. It was great to learn a bit more about your study, Dr. Wan, and the link for the paper is in the program notes for anybody who wants to access it. And I want to thank our audience for joining us on Clot Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. And if you want to stay up to date on the latest in thrombosis, hit the subscribe button so you never miss an episode. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference. Your support matters, and consider donating to Thrombosis Canada to help us continue the fight against thrombosis. Thank you all, and have a good day.